don't think انا اتلخبطت في الاسم ده. ميردرز بتاعت الاندو ولا ميردرز اللي بيقتلوا الاندو؟
كيلرز. ذا اندو ميردرز. يس ذا اندو كيلرز.
قصده ايه ميردرز؟ يلا ويلكم وذ مي.
بسم الله الرحمن الرحيم. First, I would like to extend my thanks to Professor Dr. Ahmed Abdurrahman Hashim. He is my professor, and I'm honored to be one of his students. My colleagues, Dr. Ahmed Ghubashi, Professor Dr. Shihab, and also I want to extend my thanks to the ETSIC committee for their invitations from 2015 to 2019. Okay, today we have a very interesting topic, I think. Because many clinicians are not aware about the endo murders. As in our life, there are multiple unknown murders. In the endodontic practice, we have also multiple ones. That's why we will talk about the endo murders. Okay. Who is the real endo murderer in endodontic practice? You can guess. Bulbotech, okay, or barb killers. Okay, actually we have multiple murders, but today, due to the time of the lecture, I will concentrate only on 3 of them. The first obstacle that may interact or may act against the successful root canal treatment is complexity in canal morphology. The second one is infection. Third is the procedure errors that may happen during routine root canal treatment. Let's start with the first one, which is complexity in canal morphology. Actually, Dr. Vertusi, in 2015, I think, in the endodontic topics, stated that when we have a percentile incisor with single orifice, single root canal, and single apical foramen, it is an exception, it is not the rule. So you have to imagine, what about the complexity in canal morphology in maxillary molars or mandibular molars? Okay, that's why complexity canal morphology is the gate for successful endodontic treatment. Because in the literatures, there is agreed variations among the researchers regarding the percentage or the number of roots and root canals, either in maxillary teeth or in mandibular teeth. Okay. That's why clinicians should be aware about the full knowledge of canal morphology, okay, especially canal splitting and canal merging. A very interesting study that was done by one of my best friends and colleagues, Dr. George Martin and his co-authors in International Dental Journal 2017 regarding the splitting and merging between the root canals. They found that merging between the root canals together is more common than splitting. Okay, this is for all maxillary and mandibular teeth. In maxillary teeth, usually the merge occurs at the middle third of the root canals, while in the mandibular teeth, usually the merge occurs either at the middle or at the apical thirds of the root canal, which is actually very interesting. So you have to consider when you start performing routine root canal treatment, there is something maybe different. There may a merge of the root canals at the middle third, or even splitting of the root canal at middle or apical third. That's why, as we see, they found there is a complexity in canal morphology. Using micro-CT, using combeam CT, but actually micro-CT is more prominent nowadays regarding discovering the complexity of canal morphology. But there's an important question to be answered now. Is it real in endodontic practice? When you start root canal treatment, you can imagine that you can reach all the complexities or hard to reach areas as stated by Dr. Basarani You can reach all these areas in the tooth. Is it real? Okay. Actually, this is the cases that I did. You can do it. Simply, you can do it. All these cases I did on only one concept. The way you think, the way you manage. Okay? Let's start with the way you think, the way you manage with this case. This is a very interesting case for me. It's one of my patients. She came to me, okay, suffering from pain related to mandibular left second molar. Okay, the diagnosis was acute bulbitis. Okay, I started access cavity. No, I didn't start access cavity. The first step is to completely or accurately preoperative assessment of the case is very important. Yes, all is good. Okay, so starting first with preoperative assessment. I saw the tortuous pattern of the root canal. That's why I requested a CBCT. In the view of the CBCT, as we see, there is a abrupt curvature in the mesial root. In such cases, how we can manage? Start rotary instrumentation to the apex, or what we have to do exactly routinely in your cases. First, the preoperative assessment will lead to assess the case difficulty. After you assess the case difficulty, you will respect the case. Then, access cavity was done, and always don't neglect manual glide path, because it is the first important step to reach the apex. Actually, it was not a safe trap because I broken. No. Dentists never break files, but the file was broken. It is a rule. Okay. During my trip to the apex, first file for canal negotiation was broken. After that, I tried to bypass the first file. A second file rested in peace besides the first one. Okay? So, it was very difficult for me because the file was broken, the second file was broken, her husband is a dentist. What can I do? Okay? So, nothing you have to do except to be patient with your patient. Starting the bypassing with a wedge winding motion, using small key files, with a glide path, you can reach to the apex. Okay? You can use lubrication, you can use EDTA solution, EDTA gel, EDTA cream, something like that. So, after manual glide path, I reach it to the apex. Okay? So, you have to perform manual glide path before starting rotary instrumentation. You have to check canal patency. You have to consider your irrigation protocol, which is very important, especially irrigant activation, because you cannot reach all the hard to reach areas without irrigant activation to remove all the debris, necrotic and vital debris from the accessory and lateral canals. Then, in instrumentation technique, you have to consider a crown down technique for instrumentation in such cases. Then 3D obturation is mandatory. Okay, this is the post-operative radiograph. This is 4 months and 8 months later. I was lucky. This photograph I captured yesterday. Okay. Okay. This is the first section. Okay. Questions after the lecture, please. The second section is infection, which is very important for us to know what is your exact enemy in endodontic practice. Your enemy is microorganisms. This is the most common cause for failure of endodontic treatment. Okay? It's beside the procedure errors, but the most common cause, more or less, is infection, is microorganisms. Okay, you can consider such huge lesion, how you can manage such cases. Start surgical intervention or be conservative with non-surgical root canal treatment. You have to think about this. Okay, now the question that we all need to answer. Do you can expect the behavior of root canal infection? You can expect it. Actually, you can guess, but you cannot expect. Let's go to see what's the behavior that we can see in daily practice. This is a case, this is one of dental students, okay? He came to me, suffer from pain related to the mandibular left side. See, huge infection. Here by the CVCT, as we see, is very close to fracture the inferior border of the mandible. So, always, don't underestimate root canal infection. Okay? This is the first behavior of the infection. Alternatively, we have another very interesting case. This case, I did access cavity preparation, mechanical instrumentation, complete cleaning and shaping, and then I put temporary filling for the second visit. This was done 2 years ago. The patient came to me 2 or 3 days, from 2 or 3 days, and she asked to complete or to continue root canal treatment. Actually, this was the case 2 years ago. Notice the huge, large preapical passosis, preapical radiolucency. Without any interaction, after 2 years, I found this case. There is no preapical passosis at all. It's very interesting to think about the behavior of infection. What was done within these 2 years? Is it a power of this 3D cleaning of the root canal system? Is it the power of removal of the coronal seal and the access cavity? Okay, so it is very interesting. I attributed this to the 3D cleaning, but I don't know the exact cause. Why the infection behave in this behavior? Okay, it was very interesting. You have to think about it. But when I tried to start root canal treatment, I found there is a huge internal resorption. Which may be attributed to still the initiation of the root resorption by the fact of infection. So, different considerations in your mind you have to think. This is another case. This is a patient came to me, referred to me with external and internal resorption, hapless tooth. I told the patient you have to extract and to perform an implant, but he rejected. He informed me I need to perform a crown, only crown in this case. I started a trial for revascularization, but actually it failed. After 1 year, I found there is a complete resorption and was replaced by bone. I extracted the tooth and put an implant. It's very interesting why the resorption continue. Is it by the effect of infection? Is it by the effect by intrinsic factors? You have to think. Now, we have to classify what are the types of endodontic infections. Endodontic infections, we have a primary infection, secondary infection, and persistent infection. All of them may be extraradicular or intraradicular infection. Always we can manage intraradicular infection, by the way. Now, in primary infection, such as in case of untreated canals, in secondary infection, improperly treated canals, persistent infection, there is a persistent infection even after proper root canal treatment you did. Starting with the concepts that we talk about, that we need to remember, regarding the successful root canal treatment, regarding 3D cleaning and 3D obturation of the root canal system. So don't forget the complexity of canal morphology at all. This is an example of the primary infection. It's a case the previous dentist put a composite restoration directly on the bulb, and after about 1 or 2 years, the patient came back again. But after that, we found there is a huge internal resorption. Is it due to infection? There is no previous trauma at all. Is it due to infection or due to intrinsic factors? We don't know exactly the mechanism of internal resorption, but there is a predisposing factors. One of the predisposing factors is root canal infection. Okay. Now, I started to make a challenge in this case. Actually, my colleagues advised me to extract it, but I tried. I negotiated the canal. After negotiating the canal, it was very interesting for me to stress on the irrigation protocol. I used diluted sodium hypochlorite, 1%. I used EDTA solution. I used citric acid. And after that, I tried to use MTA sealer with warm vertical compaction. I obturated the apical third. Then the area of the root resorption, I obturated it using MTA to reinforce the tooth. This is a pre-operative, post-operative, and 3 months follow-up. Regarding the secondary infection, this case was referred to me by one of my colleagues to manage the broken files, 2 broken files. Then there is still resistant pain. After he started treatment with irrigation, still there is pain. That's why I tried to manage in a different way. What is the exact cause of root canal infection? There is lack of the coronal seal, as we see. So this is the main source of infection. So never leave the patient without perfect coronal seal after obturation or even between visits, because lack of coronal seal means failure of root canal treatment. Then I found there is a mid-mesial canal I cleaned the 3 canal, then I obturated it 3-dimensionally, and I perform an offer on bleaching for my patient to come back again after 2 years to take this radiograph. This is the power of coronal and apical seal. I did only the obturation while the post-encore was done by my colleague. Okay, this is a 34 years old male patient with a persistent infection, persistent pain and swelling. I did an MTA apical, orthograde MTA apical plug for this case, but as we see, there is a huge pre-apical delucency. I informed the patient about the possibility of future surgical intervention. Actually, this is a preoperative case. This is after non-surgical root canal treatment, but after about 3 weeks or 1 month, the patient come back again with a swelling, with pain. So I make a decision to start surgical intervention after incision and drainage, 2 weeks after incision and drainage, to remove pus and something like that. This is after I did root canal treatment. And now, this is the management of the persistent infection. Start with designing incision. Usually I use rectangular flap in the anterior area because this is a huge lesion. That's why I need to manage and I need to see the field very well. Section of the cystic lesion from the flap, and then starting the preapical curettage. Real endomurder, bloody field. Now the vasectomy. So after complete curettage and vasectomy of the field, then is the rule of bone augmentation with the bone substitutes to fill the cavity. I over-augmented the area because there was a deficiency in the labial cortical plate of bone. Then I put PRF over the area of the cavity. Usually I prefer to put it not in like a membrane, but put it as a mass. Then guided tissue regeneration membrane. First layer and second layer to recontour the gingiva. Now the flap repositioning and fixation using number 5, Vicodin. Okay, this is the preoperative radiograph, post-operative radiograph, and this is the post-surgical one after filling the bony cavity. Now, we will talk about the procedure errors, but from another point of view, not the traditional view like broken anastomose management, perforation repair, and something like that. No, we will talk about another finding that may be very interesting to all the attendees. Actually, we can face such cases from our colleagues, but the time now is out. It is the rule of extraction and implant replacement, as well. To avoid reaching to this stage, you have to follow all the guidelines for root canal treatment, starting from access cavity towards 3-dimensional obturation of the root canal system. Also, you have to consider a very important concept, which is the concept of conservation of the tooth structure during routine root canal treatment. It's a very interesting case for me. It's a traditional procedure error is a broken file. As I told you before, dentists never break files, but the file was broken. Okay, so we will not talk about it, but we will talk about different findings. This case was very interesting for me. She came to me and referred because his son is a dentist. She talked about there is a nasal discharge, and she drained this nasal discharge 2 previous times by ENT specialist. At the third time, the ENT specialist told her, "I will not touch you, please go to dentist, because you have a metal post inside your maxillary sinus." I evaluated the case using COM-beam CT, and I found there is a radiopeak area inside the sinus. It's not a post. It's not a metal post. I found there is a chronic sinusitis. Actually, there is nasal discharge, unilateral nasal discharge from the right side only. Okay, but the other sinus is clear. I started Kalbelak operation to remove this foreign body. Let's go to see. Starting with flap designing, triangular flap. I reflected the flap with a micro periwestern microburst elevator. Then I accessed the maxillary sinus. Now I elevate the maxillary sinus wooden floor. Now I enter through the sinus to suck. Try to suck. See, there is a nasal discharge, the sinus discharge inside, infected discharge. I remove the tooth. Now it's the rule to remove this radiopeak mass. What is this? It's a calcified tissue. Calcified tissue around overextended filling. So that's why you have to consider what's the case with this patient after improper root canal treatment 17 years ago. This is the case. Then I close the sinus. I put, because there is a bilateral sinus opening, so that's why I closed the sinus from the socket also. It's a collagen membrane. Put bone graft. Then another layer of the guided tissue regeneration membrane, and close the flap for repositioning and fixation. This is the case after removal of this calcified tissue and after bone augmentation. Now is the time of who message. Please consider the variations in canal morphology. Please don't underestimate root canal infection. Please, it is not the matter of error you did, but it is the matter of solution you have. Thank you very much for your time. Inshallah, see you next exhibition.
Thank you, Dr. Mu'taz, for the great presentation. Thank you.